Good morning, everyone, and thank you for joining us on today's webinar designed to discuss a new state healthcare initiative for employers, both public and private. My name is Stephen Aquario, and I'm the Executive Director of the New York State Association of Counties, and I'm very pleased to have Tom Carey and Peter Nieves of WINFertility discuss some options that county governments may have to help implement or shape this new law in their community and county. I appreciate everyone calling in today. We have good representation from across the state of New York and from the city of New York, and we're very appreciative of everyone taking some time to learn about this new language that was included in the New York State budget that did include language for all employers, including counties, that must provide certain fertility coverages as part of their health insurance coverage for employees. So this morning, I'll just spend a few minutes to discuss the new fertility benefit that is authorized in statute, and also provide an overview of how the new law impacts the state's health insurance benefits, meaning the public sector benefits for us. I'll then turn the presentation over to Mr. Tom Carey and Mr. Peter Nieves of WINFertility to discuss some of the options that counties may have to implement this new law. WINFertility has been working in this area of medicine for several years prior to the state's adoption of this law. They're in a very unique position to help employers provide this new benefit in a way that I'll say focuses on the needs of the employees and helps employers like counties provide what I'll say is sort of a niche benefit in the most effective and efficient way possible. So I'd like to run through a few slides here right now.
We do want to let you know that throughout the presentation, should you have any questions, we ask you to please submit them in writing through the dashboard under questions, and they'll be sent to us, and we'll be responding to those questions in the last portion of the webinar.
That was Jeanette Stanziano from our office. Again, if you have questions as we go through this presentation, what is this insurance regulatory matter? Isn't this a program for the insurance companies and not the county employees? That's a legitimate question. You could send that into the box there for questions, and we will take questions at the end while we have our experts on the phone with us. So please, and I thank Jeanette for reminding us that if you do have a question at any time during the webinar, just type that in and we'll pull those questions up at the end. So what are we talking about here? This slide talks about an overview. The 1920 budget, state budget included provisions mandating large group insurance plans, and those are all of you on the phone that cover over 100 employees or more, and that is all counties, to include expanded coverage for fertility-related matters such as in vitro services. Additionally, all private insurance companies, regardless of the size, must cover fertility preservation, such as egg freezing, when it is deemed medically necessary, and those are important words, medically necessary. Importantly, this new law becomes effective on January 1st, 2020. So the purpose behind the statutory change was to support families to be, or women and men, who would like the option of delaying parenthood while recognizing without insurance coverage the current out-of-pocket costs for fertility treatments are often unaffordable. That was the purpose behind this statutory change. Some of the changes in the law: expanded healthcare coverage includes the following. So as we've been talking about here, large health insurance group policies over 100 employees or more are now required to offer 3 cycles or rounds of in vitro fertility services. The new requirement requires all insurance plans to cover cryogenic egg freezing, again, for medically necessary purposes. And the final change that I wanted to highlight here, it omitted prior age restrictions for those eligible for services. Prior law required coverage for those between the ages of 21 to 45 years old. Again, no longer a part of the statute. the age requirements. The law does not require individual or small group under 100 or, notably, self-insured plans to provide for in vitro coverage. Some of our counties have self-insured plans. They would not be required to provide in vitro coverage. This is notable because the in vitro requirements will be the largest cost driver, and this part will not impact the self-insured plans. However, other changes in this statute, such as services for providing the freezing of eggs, may apply to all entities providing health insurance. So some of the takeaways that we wanted to put out to all of our members today was that the following. This webinar is designed to better understand this issue and consider the benefits of choosing to provide healthcare coverage to county employees. Also, the reduction of employee stress that is related to family planning can result in a very positive outcome in the workforce, supporting our employees who want to establish a family, improving the work environment through more productive employees who are less concerned about how they will be receiving family fertility services, and again, retaining high-valued, high-demand employees and increasing employee loyalty. Now, look, folks, we could do nothing and let the private insurance market or our own self-insured plans just kind of carry on with this mandate, or we can choose to help shape this program in a manner that best suits the needs of our employees. And with us here today is Peter Nieves and Tom Carey to talk about how the county government is able to help structure and shape this program without just relying solely on the insurance companies. So let me turn it over to the folks at WINFertility, Tom and Peter.
Thank you, Steve. This is Tom Carey from WINFertility. And again, I just want to thank Steve and the team at NYSAC, New York State Association of Counties, for being such a great advocate for the counties of New York. Whenever I talk to Steve, and I've worked with Steve for over 10 years, everything goes through the lens of, is this going to help my counties? So Steve has really rolled up his sleeves and gotten to know this new initiative from the New York State budget and really understands it and sees the value that you can help employees. So I think Steve made a great point at the end. You could do nothing and say this is for the insurance companies to do, but I think from NYSAC's standpoint and where we want to help is the counties can help shape this because there's a real loyalty from helping someone build a family. And I can appreciate that being the youngest of 14 children, that getting involved with a family building benefit made a lot of sense. So my role is Vice President of Public Sector Business Development at WINFertility, and I've been in this benefit space for about 30 years, and I think this is a niche benefit, as Steve said, but it can really help people, and at the end of the day, it can help counties save money and make their employees more loyal to the county and want to stay with that county for many, many years to come. So with that, I'm going to introduce my colleague, Peter Nieves.
Yeah, hi, good morning, and thank you. I'm WIN's Chief Commercial Officer. I have a very long background as a senior partner with Mercer. I was a consultant for most of my career and probably implemented one of the first fertility programs over 20 years ago at the time with Priceline, which was a client of mine. And I've lived through it myself. I have 4 great kids. 3 of them were through IVF, and I'll probably offer some other reflections on my own personal experiences as we walk through the presentation itself.
Next slide. So, as Steve said, we could sit back and say this is up to the insurance companies to do. But again, I think from a loyalty standpoint and being able to help the employees of counties and their families, this issue, while it's a niche issue, is affecting 1 in 8 American couples. So 7.4 million infertility issues in the U.S. So people, if you just think about it, women are having babies later, there's single parents, there's the LGBTQ community. So being able to help people be more flexible, I think is something that while it sounds like a niche benefit, you're going to start to see it much more mainstream, and more states are adding to the legislation that you have to cover infertility coverage, and there's different options. So our goal today is to give you a little bit of education about how we're doing this, what WIN has seen in their 20 years of experience, and how this can be, something that really helps the counties. And we'll get into some of the ROI that we can show from this from a return on investment. So next slide. And the employee response to fertility benefits, it really shows that people are so much more grateful. Nearly 70%, there's a lot of surveys out there, nearly 70% of people surveyed show they were much more grateful from having this benefit. Almost 60% are more loyal, and over 50% stayed longer. But all those surveys are also showing that millennials have fertility benefits rated as one of the highest benefits that they want to see when they're looking at an employer. So when a county is out there competing for the best and brightest to come work for them, and they're thinking about other employers they can go to, this is the type of benefit that those millennials out there that counties are seeking to have them come work for the county for the next 20, 30 years. This is one of the benefits that they rate as one of the top benefits to see. So while it's the right thing to do, and while there's a positive return on investment for this, as you're looking to engage new employees and even employees that have been there for maybe 5 or 10 more years and are now starting to think about starting a family, this is a benefit that people want and they want to see it. And the county can get a lot of value from showing their employees that they care about them and they are going to help them build a family benefit. So next slide.
So just to give a little perspective, the opportunities here and the assumption that you would be moving forward with a consideration of a platform, or that you already are providing some level of benefit. WIN has been focused on providing very high ROI as well as improved outcomes. So what we want to spend time is just making sure it's clear as to how to unpack the opportunities in this space and to look at costs associated with it as well. Some of you may already have unlimited IUI, which had been kind of the previous mandate, and we have done studies that identify that that has led to significant increases in multiple gestation, multiple births, and very high NICU claims. So the opportunity for the inclusion of IVF may be, in fact, financially viable on its own. Looking at it from a managed and a unmanaged perspective is what we're going to spend a lot of time on. And so an unmanaged would be, to describe some of the terminologies, the unmanaged program is essentially, I have a benefit, it's offered through my health provider, but my health provider is only allowing access to network providers. There really is no management of the benefit. There's no advocacy for the patient, and there is little understanding, or any understanding, frankly, of the success and impact of a high-performing provider. So what we're focused on is decreasing cycle cost. And you do that by increasing clinical outcomes, by making sure it's being purchased through the lowest unit cost, and of course, making sure that it's medically appropriate. So that is a big focus, and we'll kind of go through that going further. Next slide, please. So WIN has been doing this for 20 years. We're not a startup. We are the largest by far in this space. We operate nationally. In fact, now we can say internationally as our advocacy. We do have experience increasing last year with a very large group that's, I believe, on the phone and public sector space. But we currently have over 5 million members on our platform, with integration and carriers allowing for access of up to 20 million. We take pride in the fact that we collect so much data on the process. We use that to evaluate doctors, which I'll get into. But being the pioneer in this and being in it so long, there's a lot that we think we're getting right, and we'll bring to the equation. Next slide, please. So we look at this as not only a fertility benefit, but also infertility benefit, a fertility benefit, but really a family building benefit. And I know in the state, advocacy is, surrogacy is not an option. But our focus is in, and increasingly a lot of employers of all types are looking at this as a way to provide a benefit to employees that's not just for those that are deemed to be infertile, but also, and if they're looking to accomplish and bring parity to the benefit for employees, for singles as well as for same-sex couples. Then that administration is something that we can also assist in. If there is any interest in adoption, as some organizations are looking at this, they see it as, well, if we're providing a benefit for one population with a fixed dollar amount or a particular cycle with a dollar value, then maybe there's something that we would provide for those that are either socially infertile or have been essentially deemed to not be capable of having or able to have children on their own. Next slide. So just highlight here, WIN has been being in business as long as we have a number of models that we can make available. We can integrate with the health plans. We can operate independently and allow our access to our network, which in New York is very, very strong. Very strong distinguishing factor is that our advocacy, which is increasingly appreciated throughout all employees, according to surveys, is that an overall advocacy is helpful. Ours is led by nurse care managers that are at a minimum of 5 years. It is something very different than any one of our competitors or any of the carriers certainly would have as offering a benefit. Our outcomes we will get into in the next slide. However, we've been able to dramatically improve the overall success of pregnancies and therefore births. We do, and we can tout, this has been validated by several of the large consulting firms around the country, the lowest overall cycle costs is what we're able to deliver through our overall clinical governance and focus on outcomes. We do have a substantial administrative flexibility. We are asked to do some fairly unique solutions. We can certainly customize to meet individual county needs. Very importantly, and different than most, we don't just provide access to any one provider group. We've evaluated all of the providers in the country, meaning the reproductive endocrinologists, there's publicly released data, and of course all the data that I mentioned that we collect. And the idea is we are looking to match the individual patient with the doctor that has demonstrated the best performance, in particular with their conditions, and allow access, help them gain access to that provider for proper care. I mentioned I offer some reflection. Went through my wife and I years ago went through 5 cycles of IVF, 6 in total. And we were very frustrated. And that was after doing many rounds of IUI, which is a lower level of stimulation. It was interesting when I joined WIN, the first thing I wanted to know was how my doctor was rated. And unfortunately, it was not rated very high. And so, we do see that those ratings have a direct and significant impact on the likelihood of pregnancy. Next slide, please. So using that data to drive the best type of care, when we actually need to update that on the 100,000 patients and help them get pregnant. But we significantly improve success rates by almost 33%. Very important, we've mentioned this, to provide the proper governance over a process. To also make sure that to assist each of the counties to design a program that doesn't incent employees to do what my wife and I did, and that was on number 5, on our fifth try, we decided to go with 5 embryos implanted, of which resulted, thankfully not in 5, but in 2, although we would have welcomed 5. But the costs associated with multiple gestations for any organization may, one, already be seen, and through analysis that we can assist you with, we can identify if any NICU claims that you're seeing are associated with IVF that may be paid for individually, outside of a plan offer, a benefit offering. But we help provide that overall. Our nurses provide the governance over the process, so that essentially reducing multiple gestations, certainly avoiding high order, meaning more than twins, and you can see the results have been significant. Single embryo transfer rate is something that we push very heavily for, or mandate with our provider, through the provider, and through the member's journey. And we've been able to, this is overall book of business, increase that, over 800%. Improve member experience. We make our nurses, the nurse is assigned to the patient throughout their journey. They develop a relationship, the WIN nurse, and the patient. They're available. We have scheduling, they can schedule all of their calls. If there's an emergency, we have nurse on call 24/7. And we just, through a third party, we're evaluated, and essentially our patient satisfaction rate is 98.3. So savings, again, we think we're focused on, of course, improving outcomes, but they see ourselves as stewards of your money, and therefore want to make this at the lowest cost, or save you money if you have a program in place. And you can see that we've been able to do that through medical, through NICU, reductions, which is dramatic, as well as overall pharmacy reductions as well. Next slide, please. Again, needed to be updated, our slide, but as I look at Tom, but we are now over 5 million covered lives. We handle very large clients with 99% client retention. We do integrate really with any. We can integrate with any. So I know there's groups in New York that are not listed here, but that doesn't mean we can't integrate with them. These are some where we have more in-depth integration, which allows for kind of different levels of management. But we can work with any carrier or TPA out there. From a pharmacy perspective, we also do have integration with these two major U.S. PBMs, as well as some of the other smaller groups. Next slide, please. So I talked already a little bit about our nurse care manager, but I think it's important. It is the underpinning of WIN's solution. The alternative, again, would be you simply call, you get a customer service person who doesn't know your patient, doesn't do any take any background information on them, and simply says, you tell me where you live, and I'll tell you which providers are nearby. And that is what we call a center of excellence model. And we feel that that's a significant disservice to the patient. Patient needs education. The patient needs emotional support, and they need to be brought to the doctor that will provide them with the best type of care, that has the most experience and proven outcomes, to work with.
And this really goes back to something that Steve said at the beginning. You could sit back and let the insurance companies do this, and they're our partners. So it really becomes a good partnership between using their network and having our nurse care manager oversee the case and be that advocate from the beginning to the end. And that's really where you get the best of both worlds. So, as Pete said on the previous slide, we have many, many existing partnerships, so it's easy for us to implement those partnerships, but the difference is in the background of the nurse care manager who's overseeing the case, and that's what leads to the positive outcomes, and then we get into the savings from there.
We didn't include slides in this for sake of time, but often we do talk and show some snapshots of the dashboards our nurses are provided. We collect data on the patient. We make sure that we understand what their benefit is so that we can explain it back to them. We will, if you offered any other programs, whether it's an EAP or a specific behavioral program, we can do warm transfers from our nurses as well. Next slide. So as far as the way we integrate in what we call a carve-in solution, if you were to say, yes, Win, we'd like to work with you, we're going to put a program in, we want you to utilize our or work with our current insurance our current payer, we certainly can do that. What does that mean? The experience for the patient is would be unique in that they put down their same member card that they have, and we would be able to integrate in with that overall experience. For those carriers that we mentioned, in particular Anthem, Empire, Cigna, we have a greater level of integration, which would result in some additional services and prior authorization that are certainly helpful. Doesn't mean that if we were to get, and this happens increasingly is happening with groups where we have large populations, so if asked to integrate, and we're doing this with a New Jersey plan right now because of volumes, and they're essentially this group of clients is really pushing that plan to integrate in with us for all the reasons that make sense. In this case, I kind of touched on a number of this, so we'll move on to the next slide, please. Thank you. Another solution, a carve out or a carve in, not to confuse it, but in many cases, it's desired to essentially make this a completely separate, non-integrated benefit. The patient experience, frankly, is nearly the same. They would get a WIN card. They'd be directed as you would, based on your relationship with your employees, direct them or educate them on how to access the benefit. They would essentially enroll with us at the time of need, and we'd walk them through and help them exactly the same way that we have, but this would be a more direct relationship with WIN versus through the carrier.
And on that note, on the carve out, when you work directly with WIN, there's a lot more flexibility in how you brand and the look and feel of the program. And again, it goes back to something Steve said in the beginning, to be able to get the credit for helping that family, build their family building benefit, to have look and feel of the county program. The carve-out solution offers a lot more flexibility there, what it looks like, the communication, and we'll get into a little bit of that towards the end.
Yeah. I mentioned earlier that we have a very strong network throughout the state of New York. We also have rates that, frankly, are as good, likely better than any of the carriers in the state of New York. So the carve-out option is certainly something that would be a viable consideration. Next slide, please. So I hit on this again because it's such a core to us, but it's worthy of a separate slide. The advocacy that our nurses focus on is about helping them understand a lot of their tests that have been taken. We have the ability to request additional testing if necessary. But the point is that there is someone that's providing them with, and when I say them, it's not just the patient, but it's also the partner, husband or significant other. We work with both, and that's very important as I get to our coming slides. But we see it as they're the patients. It's the couple. Could only be a single, of course. But we want to help make sure that there's an understanding of the male factor in all of this, which often gets overlooked, and that additionally someone's providing oversight to the doctors themselves, and that's what our nurse care managers do. Someone is double checking to make sure that the doctors aren't doing things like authorizing genetic testing, which is now very popular, and yet with our medical advisory board and the ASRM guidelines, it is not medically appropriate, and it's a $3,000 to $6,000 test depending on where you live. So those types of things, it's not been determined what it would mean to essentially biopsy an embryo, and so only under certain circumstances would our nurses approve that, and so that would be through us denied. Your insurance carrier may cover it, but we would deny it and make sure that it's consistent with what our guidelines and protocols basically require. Next slide. That overall fertility management is essentially making sure that the treatments are appropriate, that the dosing of the pharmaceuticals are appropriate, We do a lot on the pharmacy, depending on how you're essentially going through that. A big portion of the savings that we can deliver is in the pharmacy space. Well, why? It's very common for doctors to prescribe the full potential usable amount of units in the injectables. Injectables are very expensive. Of a cycle, it's about $7,000, and increasing at roughly 13 to 16% per year, like many of the other pharmaceuticals. Yet, when they send in the actual treatment plan, and our nurses will see, well, there's some smaller portion that's actually now been suggested be injected. So there's no reason that the mail order pharmacy should ever have actually fulfilled the full amount. They only should have sent them the amount that's necessary. It's called dosing management, and that, as well as staying on your formulary, which I don't care what we've been engaged with many clients who claim no, our PBM is doing that. No, they're not. We see it all the time. But we will keep you on formulary. We will do the dosing management if you elect for us to do that portion of it, and it generally saves about 33% on the overall spend on an unmanaged program. We do talk about genetics, so we do genetics in the appropriate setting, and of course we work with your patients to do that. Egg freezing, increasingly in demand, was mentioned as part of the mandate, and you would look for WIN to assist with those that are, believe the mandate is medically necessary. In some cases, it's being offered as an elective, usable up to the limit that may be made available. Clearly and totally a choice of the county. Next slide. So, very important. Certainly, this was something that I shortly after joining insisted we get into. So, as an individual and going through this process, the focus is always on usually the female, and they do need. This is a very emotional time for the couple, but it's also a need that should be and a service. A behavioral support service should be made available, and so now WIN does that. It's embedded, it's not optional. Again, we can coordinate with any behavioral program that you may have or an EAP. However, our nurses do spend a lot of time in helping individuals through their very difficult time, and so now we've developed a specialty. We have the capability and the capacity to actually refer them over to our group that's focused on behavioral support. The background is in fertility clinics doing exactly this type of work, and again available to not only the female patient but the male patient. Next slide, please. I mentioned egg freezing, and I do think that when medically necessary, it's then important to make sure you're getting to groups that have been vetted, that are as low cost as possible. But of course, that's not the most important thing. Frozen eggs out of medical necessity, very important. You may have read a year ago that there were some, for the first time ever in the industry, and there were two in 2018 labs that had failures. And so, we do make sure that we, vet these groups and those that we would send essentially your patients to, have a level of again, vetting and comfort and experience that essentially you can trust that they will do it properly and store them effectively. Next slide, please. I did mention adoption. We do that. We do this for many clients. Increasingly, they're looking at a benefit as a family building solution that is a single limit offered to the entire population that can be used for their family, whether it's fertility, those that are deemed to be infertile, those that are socially infertile, in other states, those that would be doing surrogacy or adoption. So if there is any limit and you'd like to make it a single limit under our program, then certainly we would be able to manage that. Next slide. An unmanaged program, again, these aren't the 19 is our number, but the 29 is not. This has been what has been fed back to us through multiple consultants around the country. for the overall cost of a cycle. And this is the medical piece, this is the pharmaceuticals, and generally the testing that's being added on. We're looking at a $19,000 number. It's generally between 19 and about 23,000. It depends on, you can imagine New York City is more expensive than upstate New York. Same thing with, I think, the red dot, but I think the percentage and the proportion is essentially appropriate. And so, we focus on this as, again, stewards of your money. Next slide, please. The journey, we wanted to kind of break it down so that you could see the what we bring a patient through. They'll initially, we'll talk with our customer service agent, essentially for the enrollment, for some very basic information, and then the customer service agent refers them over to the nurse that will be assigned to them again throughout for their journey. That is then their nurse. Nurse will make the referral over to the doctor, again based on the specific criteria that's been, or the specific condition of the patient, as well as their location, what's convenient. The nurse, we have no limit on the duration or the frequency of calls with the nurse. And so although we're showing 3 here, I just want to make sure it's clear there is no limit. Behavioral health support. Now, our nurses, of course, provide a lot of emotional support. If they feel that there is, they'll will introduce the opportunity for the patient and the spouse or significant other to have access to one of our behavioral health support folks. And then, IVS successful. If it's not, it's kind of starts again. We get into healthy babies. With the program, with our experience in working with so many of the carriers, we are generally then referring them and educating them on what's available with their carrier, throughout the pregnancy, and once, of course, what other support services that they have. Next slide, please. We have continued to invest heavily. A mobile-centric user experience is very, very important. Most of the patients are interacting with us through their mobile phone. But of course, we have a portal information. We offer marketing support for customized materials, just for you to announce it. We'll provide support during enrollment. And we'll share I don't believe we have the slide, but as of the first of the year, we will be doing video chat. So that nurse that they are establishing the relationship with, they'll have the ability to actually see them. And, and as we do get, although we're kind of asking our nurses not to meet with patients after, but because of the closeness that some have achieved with the patient, they often want to. So we get a lot of pictures of the babies, or offers to meet, and we can see that they can share through the video chat. Next slide. So we just wanted to share. Next 2 slides are a couple of quick case studies, then we can get to any questions. But here's an example of fairly large organization. We do like to look at everything from we boil it down into per 1,000 employees. So it gives you a good rule of thumb as to what you may actually experience yourself. And with that said, just good point, a good aside here to every county will have kind of a different experience, different benefit, different perhaps demographic, and we'll do the analysis to help identify kind of where you've been, what costs you might have seen, and what these costs would be for you. But in this case, significant reduction in twins year over year. So it's kind of a pre-win, post-win reduction in the number of twins, triplets. Just why are they so expensive? Those NICU claims, if you don't know, generally, the pricing that we see ranges, but it can be anywhere to between $50,000 to $100,000 a day for, a week for a NICU patient. My twins were in the NICU for almost 4 weeks, and very, very expensive, proposition. So, per 1,000, again, under this assumption is that there was a benefit, no increase in benefit, but simply managed versus managed, and we were able to, dramatically reduce the overall savings, per 1,000. Next slide, please. So we do use this slide generally in our communications, and we have experience across many industries. Retail, we work with all the top money-centered banks, law firms, and of course public sector. So we just wanted to share, what the savings would have been for some of these larger organizations. Doesn't mean that we don't work. Our examples here are fairly large, but we work with organizations, down to several hundred lives. Of course, their savings per thousand is under 1,000 lives is a little bit different, and maybe it will be seen over years. But I think, the one to the right, public sector, group you may know of, very large employee population with a target of significant savings. We have made a commitment to save 1.3, well, I believe it was $1.2 million a month, and believe we're averaging almost 1.3, and we're still really ramping up. So, significant savings over their previous plan, just to make sure it's in context. There's benefit provided. Now this is managed versus unmanaged, a significant difference. So the next, I think that was our last slide. But yeah. Just to wrap up, just a couple of quick points. What we walk through is, it's a much a highly desired benefit, and it continues to increase. We can share for broader distribution some of the studies. You might even just be able to simply Google it yourself, but there's so many surveys are coming out where this benefit now is rated either as the top or second highest rated benefit of the millennials in particular. The cost savings that are available through managed versus an unmanaged program, simply offering a benefit and letting them have at it, under self-funded program. That's a significant and direct access that your employees would have to your to dollars. So in any event, outcomes, saving cost, high patient satisfaction and advocacy, and frankly, we sit uniquely in the market after 20 years to deliver that service. So in any event, Tom, you want to?
Yeah, I was just going to add on to something that Steve said in the beginning, and in addition to everything we've outlined, from helping people with a successful family building benefit and a positive ROI, the county is in a position to, add so much loyalty to their employees, who will, think of that as they're being recruited, but, be retained and be there for a long time, and really remember one of the most important decisions of their lives that the county helped them to do. So, we thank you for the time from Steve and the team at NYSAC and all the counties that are on the phone, and we welcome any questions. And we're also happy to have one-on-one discussions, either in person or on the phone, with any of the counties that are here today. So thank you. And with that, Jeanette, if there's any questions in the queue, or if you want to ask questions, let us know.
Okay, that would be a time for folks to submit questions using that box, I believe on the lower right side. Yes. The dashboard is a way that you could submit questions, and we can take them. We'll go with the first question here that we have from Patrick in our office, and how Pat sort of framed this question to you two gentlemen.
This is Pat Cummings with NYSAC Council here. Peter and Tom, thanks for the presentation. Quick question for you. If a county is interested in providing this service and they're already working with a private insurance company to provide their health care, what's the next steps with you? How do they engage with a company such as yours? Do they need to reach out to their private insurance company, or do they work with you directly? And then the same question apply, but if I'm a self-insured county, what are the steps to integrate with your service?
Yeah, so I think the first step in both instances is to reach out to us directly. Because I know there's a number of counties that are on the phone, depending on who they're currently working with, we may already have an embedded relationship within the insured contract. And if they don't, then they would be, you know, and they're on the but they're insured. A carve out program certainly is probably the only way to go, is to work through us. On the self-funded, well, you know, we can work with any self-funded program, any carrier, any TPA, and so what I think is most important, and it really because we work so closely with the various payers. It really becomes a three-way conversation. You know, we'd like to gain access to some data. We're often, you know, it's requested of us to do some type of analysis. For what it's worth, the carriers and even the consultants the carriers don't necessarily have all of the codes that are required to actually track the components that we generally track. So we have to do a little bit of, deep analysis and referencing, so that we can offer insight as to what what a program cost would look like, or overall savings. So I think the first step is directly to us.
Thank you. And I got just one more question. So I know, as Steve mentioned, the law with expanded coverage kicks in January 1st, 2020. But have any New York companies already provided this service, and/or New York municipalities? And if so, what's been the outcome? What have you heard back with the results for those that have engaged with this expanded service?
So one of the ones that we have is the case study that we did for the very large public sector entity in New York with over 350,000 employees, which obviously is the city of New York. And I think they put that in for various reasons, but I think most importantly, they were looking at, how can they add a benefit to help the needs of their employees, but at the same time, really look at some aggressive savings targets that they were trying to meet. And I think we've been successful on both of those, as well as some of the New York law firms have put this in recently. So we're continually growing. We are a very rapidly growing organization, primarily by meeting the needs out there. As we've said, there are a lot of surveys that this is one of the highest rated benefits. So I think we're going to start to see more and more interest from entities in New York, both in the private and the public sector. My role is to help grow the public sector, and I'm seeing a lot of interest of people looking to, get educated about this benefit. How can they put it in? What's the best way to implement it? And what's the best way to show that it's, an important benefit for the employees, but at the same time, can it save money? And the answer to that is yes.
Okay, that will conclude the questions that we have right now. Again, we're going to make this presentation available on our website. The recording is also available for counties to present to other officials within the county at a later date. And if we have any questions or need for further information, you could see the contact information on your screen here for Tom Carey and Peter Nieves, and I'd like to thank both gentlemen from WINFertility for being with us here today. This will conclude today's webinar, and thank you very much.